Good morning, everybody. Just want to do a quick sound check. I'm a former teacher, and we were always coached to deposit our voice in the back corner of the room. So I just want to make sure those in the back corner, can you all hear me okay? How about that back corner? Nice, 2 thumbs up. I loved learning about where you all are from, where you work. And I have to say, like, being relatively new to MaineHealth, I think this is one of the best things about working at MaineHealth is just being part of such a large community of public servants that sometimes get to come together and do really amazing things. But I think what makes that so amazing is the fact that we're all from different places and we serve different communities. And our patients are different. And those experiences really allow opportunities like this when we do come together to just make it really fantastic. I'm a believer in diversity makes things better, and I think diversity comes in a lot of forms, and MaineHealth is a good example of that. So I'll just say I'm on the operations transformation team. For those that don't know that team, we've had several name changes recently. It's also a bit of a MaineHealth tradition to change names. So we used to be called Performance Improvement. Then we were called Operational Excellence for a while, OpEx. Now we're called Ops Transformation. You know, it kind of doesn't ring the same. Tried Ops Trans, that worked okay, but you know, it's like we're still finding our brand a little bit, I'll just say that. But we are a collective of about 25 people across the system, all with diverse backgrounds. Some have sort of similar training to me, some have highly clinical training and are really interested in the change process. But we are located across all of the system organizations and entities, and so I'll tell you more about who else is on my team and how you can use them in a second. But I've been here at MaineHealth for 3 years, and I'll say that my role, I've changed roles a lot in that time, and the reason is because I've been told my role is a parachute in role, which there's 2 reasons why we refer it to that. The first is it's just awesome. Like, it's kind of cool to say, like, I'm a parachute in person, so that's one reason. But the real reason is that we tend to kind of focus on specific projects and specific initiatives, and because we're only 25 team members across a very large system, we often sort of get matched up to the project that fits our skill set and our experience the most. And so I'll just share this since you all shared where you're kind of working currently or where you're coming from. I've worked at essentially 3 places in MaineHealth. The first is, and I'm so proud of my experience here, is at Spring Harbor Hospital, our large psychiatric hospital here in the system. And I'm bringing that up because they're kind of new to safe patient handling and mobility. They haven't even yet established champions. We're really working on that right now. And I was there in 2022 when there was a very critical incident that made the front page of the newspapers. And as sad as that was and tragic, it really allowed me to get in and do some really amazing work with the nurses and the providers and the technicians at Spring Harbor Hospital. And it's a really great place to receive treatment if you need to, certainly, and it's a great place to work as well. So Spring Harbor Hospital, shout out to those that have maybe worked there in the past. And certainly, if you're ever interested in learning more about Spring Harbor, come see me at the break. I'm pretty proud of my time there, and I'm still loosely affiliated with there. The second role I've had, I was the Director of Strategy Deployment, another name that's you're not really sure what that means, at SMHC in Biddeford, now known as Maine Medical Center Biddeford. Am I right on that? Did I get that right? I told you, name changes. We got to get used to these name changes. It's all good. It's all good. I'm the change management guy, but sometimes I need reminders on names. It's hard to memorize everything. So I was at SMHC Biddeford, MMC Biddeford, for about a year and worked a lot with the what they called the rehab team. And I'm just curious, do we have anybody from the Biddeford rehab team? Oh, I remember y'all. Yeah, good to see y'all. And I have a special place in my heart for that time, very brief time I worked with your team for a couple of reasons. One is you let me call you a name, so I told you name changes. You let me call you a name that was really more from my experience as a principal. As a principal, I leaned so heavily on the work of occupational therapists, physical therapists, and speech and language pathologists. In fact, I would consider some of the work that I saw them do truly miracle work with children. And my own son, was diagnosed on the spectrum pretty young age. He's now sort of non-diagnosed on the spectrum, which is interesting. But in his early years, he benefited so much from the work of an occupational therapist in his life. And so I just want to give a shout out to the PTOTS team. That's what I called them, PTOTS. It's because what I always called them as a principal, but it turns out nobody's ever used that term. So thank you for letting me call you that. I'll just call you the rehab team now because that's what you are. But so I was there for about a year. And then I got really sick with long COVID. I don't know if anybody's ever gotten long COVID before. You see the word long, like long walks on the beach, long gazing stares. You think that's positive? Long COVID is not positive. Long COVID is a bear. And it required me to sort of change some roles, take some time off medically. And I did that at the start of this year. And since I've come back, I've been parachuted in back to behavioral health a little bit, but now I'm engaged mostly with the medical group and primary care practices. So if anybody's affiliated with those, you may see me there. So that's my introduction. I just want to say it's truly an honor to be with you all here today. This conference is so fun to come together, as we said, and I love conferences. I don't know if I'm the only one, but conferences get me excited. Especially good ones, and this is a good one, and it's not really because of what I have to say, it's really more what you have to say during the part that I'm leading, and then following that up with some breakout sessions later. So thank you for being here. This is more than just a meeting. It's really a celebration. It's a celebration of the incredible work each and every one of you do every day to keep our patients safe and our colleagues safe, and to foster that culture of care that extends far beyond the walls of our hospitals and our clinics. So I really want to recognize you, the ones who advocate for safety, educate and support your peers, and ensure that safe patient handling and mobility practices are not just policies on paper, but are instead living, breathing actions that protect lives. I'm going to say that again. Safe patient handling and mobility practices are not just policies on paper, but living, breathing actions that protect lives. Your resilience, your dedication, and your hard work make all the difference. So on behalf of my team, the Operations Transformation Team, as well as Kate, Angela, and Jen, the Safe Patient Handling and Mobility Team, thank you. Thank you for doing what you do. But also thank you for showing up today. I know some of you had some drives to get here. I know some of you are like, darn, these things I didn't get done yesterday, I'm at a conference today and I gotta somehow rearrange it and get it done by, I know, I'm in the same boat, we all are, but I just wanna say thank you. Thank you for being here and taking the time. And let's just sort of marinate in the fact that we are not doing the normal things we do every day, and instead we're here, we're learning, and we're engaging in some new ideas that hopefully we can take back to our practices. So, our vision at MaineHealth around this topic of safe patient handling and mobility is an ambitious but yet entirely achievable vision. We aim to create a minimal manual lift environment. That's the policy. That's the official MaineHealth vision on safe patient handling and mobility. That we seek to be and create a minimal manual lift environment. This isn't just a nice idea. It's a necessity. Every time we reduce the need for a manual lift, we reduce the risk of injury. Straight up. Every time we follow these practices, we help not only patients, but our colleagues. Every time we advocate for the right equipment and ensure that it's used properly, we protect not only our patients, but ourselves. But to truly realize this vision, it takes more than just implementing a policy. It can sometimes require a cultural shift, a change in behaviors, a paradigm shift. And that's where each of you come in as the safe patient handling and mobility champions. So I'll let that sink in for a second. Cultural shift, behavioral shift. I don't know about you, but sometimes when I hear that, it's like, get a little heart nervousness, palpitations, a little bit of that shortness of breath, because it's like we know changing human behavior, even in ourselves, is not easy. Somebody who worked with middle schoolers most of my career, it is really hard to shift behavior. However, you can, and that's what we're here today to talk about. So, as I said, each of you are champions. And in some ways, by me being here, I'm a bit of a champion of safe patient handling. So, in some ways, we are the champions, my friends. So, it's hard not to say we are the champions without thinking of this phrase. So, in all seriousness, though, this word champion is often used a lot in MaineHealth. And I'm going to just say, love it, celebrate it. We are the champions. Woohoo! Right? There's some really great things about being a champion. And there's some really hard things about being a champion. We are sometimes put in positions with our colleagues that are not easy. We are sometimes asked to think on our feet and respond to situations happening in front of us, and they are not easy. So I just want to recognize each and every one of you that, like, yeah, you're a champion, but sometimes that word champion can have multiple feelings attached to it. And just like we get heart palpitations and breathe a little short when we think about changing somebody else's behavior, I think a lot goes along with that with being a champion as well. It can be both exciting and also a little nerve-wracking. So, I get the feeling that you're saying right now, well, Josh is telling me I'm a champion, but I don't always feel like one. So, you know, because of my work with the Biddeford team and Spring Harbor teams, I feel like I get what safe patient handling and mobility is. Like, I sort of get it. I understand it. If I was working on the floors and teams and practices with you all, you wouldn't need to convince me. Like, I get it. I see the work, I know the value. But y'all know that your teams are not always filled with people like me. Thank goodness for you. But you get the idea. Like, it's not always people like me that needs this cultural shift, this paradigm shift. Instead, it feels like sometimes it's others that we need to see things differently. And that's really what today is all about. We're really going to dig into that concept of what do we do when we know we rely on others to shift, but yet we don't always know how to do that. So I have a little activity for us to kind of get into that mindset. It's like a warm-up activity. Each of you should have a sticky note pad in front of you. And I'm going to collect 1 or 2 stickies from each of you right now. And I'm going to tell you in a second what you're going to write on them. So before I do that, though, I want you to try to think about the people, like actually, I know you're in a room in Scarborough right now, but like in your mind, try to like go back to like visualize where you normally do your work. Where's the coffee machine? Where's the fridge? Where's the patient areas? Where's the, you get the idea. So think about where you do your work. Now I want you to think about the people you work with. Actually, like, put their faces in your head right now. Kind of scroll through. Who are those people you work with? And some of them you might be like, you're like looking behind you, like, hey, I work with the people that are here with me now, which is great. Think about the other people, too. Now I want to introduce something to you called it's basically thinking about things in good faith efforts. And I have a really strong belief about this. And I'm in change management, and I've worked through a lot of difficult changes. And sometimes when I'm working with people, I'll be like, well, how's it going on your team? What's happening? And oh, these people won't change. It's these people's fault. These people won't change. And I'll say to them, well, are they acting in good faith? So let's ask, what does good faith mean? In my mind, it's very simple. Good faith means that I am acting because I believe I am doing the right thing. Notice I didn't say, I'm acting because I'm doing exactly what my colleague thinks I should do, or I'm doing this practice exactly as my boss wants me to do it, or as my colleagues wants me to do it, or I don't define certain things the same way. Good faith is just simply saying, I'm doing it this way because I believe I'm doing the right thing. I personally believe that, especially in public service, the ratio of people who are acting good faith is at least 95 to 99%. I believe that strongly from experience in MaineHealth in my former career. So when somebody says like, well, these people won't change because they're not acting in good faith, I struggle with that a little bit. Because I don't know if the reason they're not changing or doing things the way that you hope they would is because they're not acting in good faith. They're trying to do the wrong thing. I think if you really listen to them and ask them, what's going on here? You might find that actually their reasons for why they're doing it that way are very much rooted in wanting to do the right thing. Okay, so that's my little soapbox about good faith. Now go back to your colleagues, go back to where you work, and I want you to think of a member of your team, and choose somebody that you work a lot with, not somebody that's per diem, that's there once a month or something. Like, choose somebody that's a core part of your team that you can say with surety that they generally act in good faith. So that should be pretty easy to do, right? You can probably think most of your people act in good faith on your team. So think of one of those people. But also think of a person that's in that category of good faith that is also generally resistant to things that you might want them to try differently. Okay? I see some smirks. I see some sort of, we all know these people. Like, and I've been these people to other people. I am sure of that. These are the people that you just know, like, I'm going to bring back this idea, and they're going to question it, or they're going to say, like, yeah, that's a good idea, but I'm going to do it this way, right? Can we all think of that person? Okay, great. Shouldn't be hard. Remember I said earlier about diversity? This is, I think, one of those examples of diversity. You would not want to work in a place where everybody agrees with each other all the time. Sometimes diversity is diversity of approaches, diversity of practices, diversity of values that drive actions. Okay, does everybody have that person in mind right now? Somebody on your team that acts in good faith, but that would likely question. On your sticky note right now, I'd like to take 2 to 3 minutes, and I'd like each of you to come up with 1 to 2 sticky notes. And here's the prompt. If you were to run into this person at the water cooler, in the kitchen, in the hallway, and they said, where were you yesterday? And you said, oh, I was at the Safe Patient Handling and Mobility Conference. And they said, oh, cool, what'd you learn? And let's say you said like 2 or 3 things that you learned. And let's say they had a response that wasn't super supportive of some of the new ideas that you bring back. How would they say it? What specifically would they say to you in that water cooler moment in the hallway when you said, oh, I learned about this cool thing where da-da-da-da-da, and they were like, yeah, but no. What would be the no? Write it down right now. Everybody take 2 to 3 minutes. I want 1 to 2 stickies from everybody. 30 more seconds. All right, I'm going to popcorn around to just a couple that I saw that to me really spoke to what I thought. So here's one. I'm old school, right? I've been doing this since the Johnson administration, okay? This is a new administration. Yeah, I'm not doing that. You gotta love direct communication. I have to say, there's parts of that that I respect. Who's got one in this area that feels like would resonate with the room? Thank you. Oh, this is a good one. None of the CNAs and nurses on blank unit will do that. Interesting. None of the CNAs and nurses. Maybe the P-totters will, but the CNAs and nurses won't, right? So that role-specific resistance. That's a good one. Others? This is a very specific one to safe patient handling and mobility. I like this one. What if the floor doesn't bring the patient down with the sage mat or Hoyer pad? The old what if response. I'll do it, but only on Tuesdays if it's raining and the moon is in the right place in the atmosphere. Then maybe it'll work. That's a good one. Others? Popcorn. What are some other ones? You know what? I am so glad you had a great day at the conference yesterday. I hope the food was good. You can be like, yeah, it was good. Have you seen the snacks back there? They are good. Here's the best one, though. Love it, love you. We just don't have time, though. Love you, though. Love you. Love that one. What else we got? Ooh, oh. This is the real zinger. This one has a couple different parts in it, but this one has the one that's like the ultimate yeah but, especially in the year 2024. We'll never have enough equipment to make that happen. Okay, some of those might be actually fair things that you can work with. This one, though, the second part of this one is the one that you hear a lot. We will never have enough staff to make that happen. Are they wrong? Will we ever have enough staff? Are they right about that one? Yeah, that is a constant struggle. But to sort of end it just as like, well, sorry, staffing, end of story, that can be challenging to hear. What others? Other popcorn ones? Anyone else have another one? Great. You are getting participation points, by the way. You already have a check plus in my world. Okay. Oh, this is a good one. Especially of a conference one. That sounds good in theory, but it won't work here. It's like, where will it work then? It's like, if it's a great theory, ideally it should be able to be applied in some way, in some capacity here, but to say it won't work here, that's an interesting one. We're going to dig back into that one later. Anyone have another one that's kind of like different than what we've heard so far? That would resonate? Yeah?
There's not enough room to do that.
Oh, there's not enough room to do that. Yeah, that physical space issue. Kind of like equipment, like there's some real valid concerns there. And so hopefully what you heard in this exercise, oh, and by the way, Kate, Jen, and Angela, could I have your help? So could everybody please pass, everybody here pass to this center aisle, and everybody here pass to this center aisle, and so we'll walk down the aisle. We're actually going to do something with these, and you'll see, you'll be able to kind of write these down later so you can leave with these. We're not stealing them permanently from you, but we're going to actually gather them to collect them for an activity that we're going to do later. Hopefully what you heard in some of these responses is Remember, I started by kind of prompting you around this issue of good faith. That can be really hard to sometimes always assume good faith in others. It can be really hard. I have felt that firsthand, where you just want to be like, my 12-year-old daughter uses a lot of initials, so this would be in like the WT blank category, but like, are you serious? Like, really? Like, that's how you want to like respond sometimes when you get some of these, right? It's like, come on, like, and so it can be easy to sort of assume, well, that person's not acting in good faith. They're acting out of laziness, they're acting out of selfishness, they're acting out of sort of NIMBYism. NIMBYism, not in my backyard. So sort of like, I love the change in the world, be the change, woohoo, be the change, you was just not here, right? It's really hard when you face those moments to be like, I'm gonna lean into that person. I'm gonna lean into what they're saying and actually assume that they're trying to do the right thing just like I am. And so that's something we're gonna kind of come back to throughout the day. And you'll see what we're gonna do with some of these things that you wrote down. We're actually gonna dig and create a tool that you can use when you leave here and go back to your system. So every one of the things that we just did, we call them yeah buts. It's like yeah but, right? Like yeah, but, yeah but. So yeah buts are actually like something that's taken me some time in my career to really gain patience and understanding around. And I think when you change your mindset around yeah buts, and instead you see it as like, they're saying no. And one of my favorite movies is Dumb and Dumber from the 90s. And at the end, Jim Carrey realizes this woman he's been longing after isn't interested in him. And she goes, there's no chance. I mean, 1 in a million chance. And he goes, so you're saying there's a chance? Like, that's how I kind of have learned to think about yeah buts. Yes, they're throwing something at me, but as much as you want to just swat that back and say, WT blank, like, I've learned to kind of catch it. I've learned to catch it and say, what is here? What is present? So you're saying there's a chance. What are you saying there's a chance around? And then let's build from there. More to come on that. All right, so let's go back to the vision here at MaineHealth. What it actually means to create a minimal manual lift environment. It means that no amount of patient weight is safe to lift. I'll say that again because that's really important. This vision means that it's no amount of patient weight is safe to lift. However, it also means reducing the force and frequency of manual lifting. Did you see there? There's nuance. Just like everything in the world, this is nuanced. It doesn't say zero manual lift environment, it's minimal. Because we know that no amount of weight is safe to lift. However, things happen. You have to respond in the moment. So therefore, it's about reducing the force and frequency of manual lifting. Yes, we know there's always going to be some sort of manual interaction. Yesterday, I was in a primary care practice in Westbrook. The MA was walking in front of a patient, and it was an older gentleman. He started to sort of list, and I thought he was going to go down, and the MA just hadn't quite seen it yet. A couple other people did the same time I did. But before I knew it, and I'm not even trained to be doing this, I'm sort of in a position where I'm like, okay, if he goes down, I'm going to at least be there to sort of, and these things happen. Like, so it's important to know that things occur in a setting that you're not always prepared for. He did not go down, by the way. He said he was just moseying. I'm like, I didn't know that was okay. So we know there's always going to be some sort of manual interaction in how we care for patients, but by committing to being a manual lift environment, it means that all of us need to sometimes rethink the way in which we approach patient care, especially if we've been doing things a certain way for a long time, even since the Johnson administration. It means integrating safe patient handling and mobility best practices into every aspect of our daily routine. I hate to say it, but that's very true. This is one of those things that it's not like a sideline, maybe think about it sometimes kind of thing. Safe patient handling in mobility does really need to be built into every aspect of our routines, and how we work with patients. It means encouraging patient participation in mobility, including the moseying part, and allowing them to move themselves as much as possible. It means committing to, as a collective, as a team, as a unit, it means committing to prioritizing safety above all else. Y'all heard the staffing issue? We don't have the wiggle room to lose staff members to these types of injuries. We just don't have it. So it's even more present today, given the staffing issues that we know we're never going to solve. Maybe politically we could solve them in several years or something like that, but the issues facing staffing in Maine and elsewhere, it's not just Maine, these are not going away. And so it's sort of like, how do we, in this new world, reduce the risk and the frequency of staff injuries? And it's safe patient handling and mobility. All right, I'm going to tell a little story to you about my time as a principal. So, and it's helpful. Please know, like, there's all love in my heart when I ask these questions. This isn't me doing the like generational comparison. I identify as like Gen X. I'm sort of like late Gen X. My wife identifies as millennial, early millennial. My children are very much Gen Z. So this is like, I'm not judging the other generations, but I'm curious if anybody was in a school as a student during when this story comes from. So please raise your hand if you were a middle school or high school student sometime between the year 2002 and 2009. Good, that's great, that's awesome. That's when I started teaching and when I started becoming a principal. And I say that because this story may resonate with some of you. So here's my story. So I was a principal, assistant principal and principal at Mount Ararat. I was also a teacher there, as a social studies teacher. I taught 9th grade. And yeah, if you've ever had a 9th grader in your life, you know what that's like. But here's what I would say is it was a very exciting time for one specific reason, a lot of reasons, but this one in particular. It was when there was this thing called MLTI. Recognize it? MLTI? Maine Laptop Teaching Initiative. We were the first state in the country to provide free laptops to every middle school student. We started in 2002. In 2007, it rolled up to high schools. This was a really exciting time, at least as a teacher and then as a principal, to be working in public education. It was such a different, I'm sorry, it wasn't that long ago, but like, maybe I'm just, as a parent who just went through the pandemic with my own children at home, it's like shifted my views a lot on this, so I'm acknowledging that. But like, back then, it was, and Angus King, who's now our senator and running for Senate again, and I'm not judging or criticizing him, I'm just saying he had a very clear vision as governor that he believed that these technology devices in the hands of middle and high school students would do nothing but good. In fact, you should read some of the original legislation. It is like we are handing down the tablets on the burning, the mount or something. Like, they really believed that like nothing bad could happen if we give technology to young people. This was, so 2007 was when it came up to the high school, and I was a teacher before that point, but that was also the year I became an assistant principal. And 2007, the primary social media program was MySpace. Is that ringing a bell? Facebook had like literally just started the year before. Kids were starting to use it. Adults definitely weren't using Facebook in 2007 and 8. But it was this really interesting time where it was like, nothing bad can happen. Just give them access to technology. Let them use it as much as they want, in the classroom, out of the classroom, at home, anywhere. It's all great. They can just, the world is at their fingertips. That was like in the legislation. The world is at their fingertips. All parts of the world are at their fingertips. The good parts and the not good parts. And so what was happening is, that was when I was a teacher, early parts of that, and then it was 2007 and 8 when I became a principal. And what I remembered is that I remember thinking, yeah, but I'm seeing some not so good things start to come up. MySpace, was horrible for cyberbullying. Horrible. Horrible because the parents didn't know how to use it. Some of you who are at that age are probably like, oh yeah, it was great. We got to do whatever we wanted. And the challenge is, it was rough. I started to see some really rough things occurring with social media usage. But I was also seeing that in the classroom, the teachers weren't really sure yet how to supervise the students with their laptops in the classroom. So for the first couple of years, a lot of teachers just had them keep them in their backpacks. And then that was a problem because then nobody used them. And so there was a big push about 2005. I was a teacher, I remember this. Like, get them out, just get them out, open them up. Open it up. Get it out, get it open. What I also saw was that many students could handle that. Sure, teacher's talking, I'm sitting here, laptop's open. I can just not touch my laptop and look at the teacher when the teacher's teaching. However, I also saw that many students did not do that. Many students were playing Wolfenstein 3D, the shooter game. Minecraft had come out at this time. You had a lot of kind of social media, gaming things happening literally in the classroom. And again, this was when I first became a school leader, and it was like one of my first policy changes. I was like, teachers, we need to do this whole laptop in the classroom thing differently. And I had a very specific policy change I requested of them. And you can almost see it in this room here. So I'm at the front of the room, right? You're all looking at me. Imagine if you all had laptops open, right? Some of you do. Can I see your laptop right now? Can I see what's on your screen? No, I can't. So that was my idea. Let's just shift how we do laptops in the classroom. When the teacher's at the back of the room, it's fine. The laptops can stay where they are. But the moment the teacher comes to the front of the room, we need to shift how students sit, and we need to shift the screen. I've used the word shift several times now. So this is an example of me trying to shift behavior of the teachers that I worked with. So I said, it's very simple. So all you're going to do is, if you're sitting here, you get up and move your chair here and put your laptop screen facing the teacher. So it required that, a couple things. It required that the students move every time the teacher moved. And it required specifically that the teacher never not have their face facing the screen of the laptop. It was like I had asked them for one of their organs. Like, the resistance from teachers was so strong on this one. Because so first of all, they were kind of like, hey, my classroom. I get to set it up the way that I want to. Kind of true. But what if there's rampant harm happening to students and you're not aware of it and you're not dealing with it and being able to effectively supervise it? There was a lot of concern around just like, I don't need them to do that. Yeah, no, other teachers do. Other teachers, I know. Now look, I know there's a problem in other classrooms. My students would never do that to me. My students they respect me. When I'm talking, sorry, this is actually something I thought at the time. My lessons are so interesting that they would never think to start gaming or going on social media. It's just so captivating. Of course, part of this initiative was I had the technology department install what's called desktop monitoring. So essentially they can run reports on what the kids are actually doing. And that was one of the ways I addressed it. I actually just handed them data reports and I was like, cool, that's awesome that you have such captivating lessons. Did you know that 40% of your students weren't listening to that lesson because they were actively sending messages on MySpace during this time or Facebook during this time? So it was a really interesting one of my first change management moments as a leader was trying to figure out how I can convince these teachers that this policy change is the right move for them. And so one of the ways was data. I just showed them data, and I wasn't personal about it. I wasn't like, in your face. It was just like, cool. Let's look at the data and see what it shows. That's great that you observed that. So that one of the ways was data. The other ways was just helping them understand the harm of what would happen if they didn't supervise something. And sort of what the experience would be like for somebody to be like, This is happening in my math class. I'm getting bullied by somebody in the back of the room during math class. My teacher isn't stopping it. Like when you said it like that, I found a lot of teachers were really influenced by that. They were kind of like, oh, well, I don't want that to happen. I thought I knew what was happening on my students' screens, but I really didn't. And so it took about a year of going through this challenge and change. It was data, it was telling stories. It was also just like saying, try it. Just try it. It will not be as disruptive as you think. In fact, you might be surprised to learn that the students themselves actually want this change. They want a little bit more supervision. They feel good when those boundaries exist on them. And so, as we kind of think of this story, and by the way, not that I would do this, but like, I was kind of proven right too. Like, it wasn't long before people started to realize, technology isn't necessarily the panacea that we want to give to a 12-year-old or a 14-year-old. Like, there might be a middle ground here. And effective supervision of student usage in the classroom started as a novel idea in 2008, but really became standard practice by about 2011. And frankly, it became state law. The state law changed around cyberbullying in 2011, and it required specifically that teachers not have students use the laptop in the classroom unless they could directly supervise it. And so this was one of those things where I just happened to get ahead of something that was coming anyway, but the resistance was strong, but I sort of just chipped away at it. And as much as I wanted to say, like, you're wrong, I'm right, I could have, but I didn't. Instead, I came at it of like, tell me more. Why do you think that you don't need to have this change happen? And often it was just breaking down reason by reason. I was catching their responses. Instead of pushing them back to them, I was saying, okay, let's understand that more. Let's find some more data. Let's tell some more stories about that. You might be thinking, what does this former middle school principal, former teacher, know anything about healthcare? But I will tell you, the parallels in education and healthcare can be striking sometimes. In both education and healthcare, our work is built on collaboration and trust, and the relentless pursuit of outcomes for the greater good. I'll talk more about that in a second, but you can't underestimate that how committed, at least in my time in education in Maine, my colleagues were to the outcomes of what we were doing in those schools. Like, they were, it's gonna make me emotional. Like, I loved that work because I knew how much they cared, and I would watch them care, and it would inspire me. And that matters. We're lucky sometimes to be working in public service because not all industries have that level of commitment, and healthcare and education do. And I'm so proud to be working now in healthcare. But just like in education, change in healthcare can be daunting. But with the right leadership, your leadership, we can achieve some pretty remarkable things, and that's what we're going to work on today. All right, so let's talk about some of the best practices here. Whether you're a seasoned expert or new to safe patient handling and mobility, you are all vital to our mission. Being a safe patient handling and mobility champion isn't just about knowing best practices, it's about living them every day, modeling them every day. And by doing so, you're inspiring others across our organization that we truly are a minimum manual lift environment. Do you know how many times our care team just gets shown little snippets of policy points and vision points and SOPs, and there's this new this, there's this new that, do this, do that. It's a vision combined with on-the-ground champions that really bring about change. There is so much being thrown at our care team members. So if we can throw something at them and back it up with real role modeling and inspiring them to change as well, that's really where the magic comes in. Because we know that this means no amount of weight is safe to lift. It means reducing the force and frequency of manually moving patients. I'm going to say it again. This means no amount of patient weight is safe to lift. And it means reducing the force and frequency of manually moving patients. Here's the thing though. Your work as a champion happens in two critical arenas. The first is on the floor. When you're doing direct work with patients. When you're actually coaching or redirecting colleagues during direct patient interactions. This is where your real-time interventions can make all the difference. Your role modeling can make all the difference. It ensures safety protocols are followed and that we minimize the risk of injury for both staff and patients. The second arena, so again, the first one is the sort of on the ground, role modeling moments, teaching moments, teachable moments. But the second is, and this is where my team comes in, because my team kind of owns this process a little bit, or at least we own coaching around this process. And what I'm talking about is huddles. And huddles are something that come in a lot of different forms. Huddles is one of those terms that's probably changed names. I used to call them stand-up meetings. I stole them from the military when I worked in schools, but they're really the same thing as huddles. We now call huddles things that aren't huddles. We huddle a lot. It's like we're over-huddling in some cases, but the huddle I'm talking about is kind of a specific one. It's that team-based huddle. Ideally, those sort of daily huddles, those daily check-ins. The Biddeford P-TOTS did it at 1 o'clock every day. That was their huddle time. Is it still that time? Great. It's kind of their time to come together. It is the prime time. Often, you huddle in the morning with your team. Some of you might not have a daily huddle, and that's okay. Part of the outcome of this is maybe to help, reach out to me and a member of my team, and we can help you set up huddles if they're not already in existence. But huddles are a really important arena. If that first moment is the in the moment, on the ground, direct patient care moments, teachable moments, we're actually touching a patient and we're coaching a colleague, that's one arena. The second arena is at the huddle. The huddle is the designated space and time where all team members can raise and discuss safety issues, including safe patient handling and mobility practices. You are one of those team members. So the huddle is the place where you can talk about this issue as a champion. It's really hard to get a listening ear in healthcare. It's really hard to get the undivided attention of your colleagues. But a huddle is a place to do that. I'm not saying it's perfect. I'm not saying everybody's there every day. I'm not saying there's not distractions on some days. But it is the system that we have in MaineHealth to get the word out on some of these things. So if you're not already thinking about your role as a champion, as your role during huddles, that should be one of your outcomes for today. To think like, ooh, I'm not using huddles as much as I could. I want to think more about that. Because this is where you, as a champion, can drive the conversation, highlight the importance of using the right tools, and ensure that our safe patient handling and mobility standards, the ones that you have in your folder there, are consistently applied across the unit. If not you, who? If not huddle, where? That's an outcome I want you to be thinking about. That's a shift that you might need to make in your mind this morning as you're hearing this. And the good news is we have the tools here today that can support you in that. That's really why we're here. So, in our team-based huddles, we do create an open forum for interdisciplinary information sharing, planning, and strategizing. Yeah, it's only 5 minutes a pop, hopefully not more than 5 minutes. But these little blocks of time, especially if they're done consistently and daily over longitudinally a period of time, it really is where you can actually have those real conversations. So think of your huddle as a pre-flight checklist. I'm flying in a couple weeks. I'm taking my family to Colorado. It's one of the first times we've left New England since the pandemic. And I'm realizing my children have not flown since they were like toddlers. And my daughter's very nervous about it. She's 7th grade. She's just like, I don't remember when I was on a plane. She's really worried about it. And I'm finding that I'm having to talk to her about, well, you don't need to worry because the pilots and the flight attendants, they're checking the plane. She's like, no, they wouldn't check the plane. I'm like, yeah, No, every time a plane goes off, we'll look out the window. They're walking around, they're inspecting the plane. They're kind of thinking, okay, what do we need to know? How much weight is on this plane? What are the particular weather concerns that we need to be aware of? How's any maintenance issues we need to be aware of? And so those pre-flight checklists that I'm talking to my daughter about in aviation is kind of what huddles are. So just as pilots gather crucial information to ensure a safe flight, huddles allow us to gather and disseminate the information needed to ensure a safe shift. They're really that simple. So again, if you don't already, if this isn't, you're like, that doesn't sound like my huddle, we don't do that kind of stuff there. This is where you need to reach out to my team, because our job is to help teams have the most effective huddles possible. And again, that's what I'm working on right now in primary care. We're going to every primary care practice. I'm spending some time with them, and I'm helping them feel like their huddles are the best that they can be. So again, as you're hearing this, think to yourself, if this doesn't sound like my huddle, that should be one of my outcomes of this conference, is I need to work on huddles a little bit. But the good news on that is you're never going to be alone. Your leaders and teams like mine are here to help you. It's in these moments at huddles that we reinforce the importance of this vision of safe patient handling and mobility. Just as pilots gather crew, it's in these moments that we reinforce the importance of this vision here. Address any barriers to implementation, and the best part about huddles, it's also where we celebrate successes. And I think there's some real opportunity to celebrate some successes from today that you can bring back, and actually, sometimes the best entry into a conversation about improvement isn't highlighting what's working poorly, but to highlight is what is working well. And when you celebrate first, it allows a great arena to say, sometimes it's the most resistant person that loves the celebrations the most. And you'd be surprised, some of those resistant folks that we heard some of their examples earlier, if you celebrate what they are doing well, that actually might be the most vulnerable moment for them. When they say, yeah, I feel really good about that, but you know what, I got to work on this other thing. And I find sometimes it's celebrations that give them that introspective moment to sort of be like, no, maybe there's something I can reflect in myself, not just the positive, but something I can improve on. But if you don't celebrate and you don't create an environment to celebrate, it's really hard for those moments to happen. And frankly, that could be some of the reasons people are resistant to change, is that they aren't getting recognized in the good work that they're doing. And then so they're like, well, heck, if you're not going to recognize me for doing good, I just am going to assume you think I'm screwing up all the time. And that's a really lousy feeling, to feel like your boss or your team thinks you're screwing up all the time. It's going to put your dukes up, and you're not going to be in a position to change. So let's be honest. Why aren't these best practices always followed on the ground? Sometimes it's due to time pressures. When there's a rush to get things done, shortcuts can be tempting, right? I can relate to that. When that man was wobbling in the hallway yesterday, I knew I wasn't trained. I knew I wasn't the person to catch that guy. But I still was like, whoo. You know, sort of, things happen in the moment and quickly, and it's those time moments where a rush to get things done, shortcuts can occur. Sometimes it's due to habit. Hopefully you saw that in the example with my teachers and the laptop screens. They were kind of feeling like, no, things are going great. I'm doing good lessons. Yeah, my laptop screens are open, but they're still listening to me. I'm so great. I'm a great teacher. And it was like, yeah, sometimes data is what can break a habit sometimes. Sometimes just showing somebody the data that like, I love that habit, you feel like it's working for you. Love that. But let's see what the data says about that too. Sometimes it's in those moments that you can get some introspective. Remember, we all wrote down those yeah buts earlier, and we're going to come back to those. We learned through some of those examples that sometimes the biggest reason why resistance occurs, and this is where I want you to really try to find the most empathetic, open part that you have with you this morning. Some days we have like a huge part of our body that's really open and empathetic. Other days we kind of like, that part is really slim right now. So hopefully y'all walked in with a fairly open and empathetic kind of approach to yourself today. And if you don't have a large one today, find the small sliver you have, because this is probably the biggest takeaway from today that I want to help you understand, is that when you yourself think about how can I change the behavior of others, it's so important to start with this basic idea, which is that change is hard. It is hard for people to change. I'm going to nerd out for a second here. There's a lot of brain research, and this is one of the best things about working with middle school age kids, is like their brains are literally developing and growing in that moment while you're working with them, like sometimes day to day. Sorry, I have a 7th grade daughter, so it's been a rough weekend with some social media stuff. And it's like I'm literally watching her change in front of me, because she's like, this, and I'm like, okay, but there's another way to look at that, this. And even just this week, I'm seeing some of the change start to come in some of the conversations we're having. Most conversations this week are not going well. I'm just going to admit it. Like raising a 7th grader is not easy, and it's partly because change is hard and complex. And so I think it's important that we just rest on this core idea. You have the power to empathize with your teammates. That's something you're in control of. And I know your gut instinct might be to drift the other way and kind of go to a blaming place, but by doing that, you're only hurting yourself. You're only hurting yourself and your ability to be a champion, to be a change leader, to be somebody that can model and then help bring about changes in their unit and on their team. So it's that unique ability that you have to lead by example, to energize your teams and ensure that best practices are followed. They aren't just known, that they're embraced. It's those moments where if you start from this place of just empathizing, that why is it hard for them? What is the reason that it is so hard for them? We saw some examples earlier of why it could be hard for them. So what if we just paused and said, what is it that they're saying that I can use something that they're saying and work with it? And we'll see some more examples of this in a second. Consider this. Every time that you demonstrate a correct lift on your team, you're teaching. I told you I was a teacher, I was a social studies teacher. Everybody can be a teacher. That's what's great about teaching. Yeah, you can be a licensed educator in public schools, but a lot of you are parents, just like me, and you are teaching all the time. A lot of you are aunts and uncles and friends, and you're teaching the people in your life all the time. And so, like, often we have these moments where we're like, I'm in a professional environment. You make a salary, I make a salary, or hourly wage. We shouldn't have to teach this person. Yeah. Okay. Can we move on? Are you done? That's kind of what's happening here. It's like we are resistant to teach because we think we shouldn't have to teach. But I think if you approach everything from this mindset of change is hard and complex, it allows you to see yourself as a teacher. Every time you take that extra moment to ensure safety, you're leading. Every time you share your knowledge, you're empowering others to do the same. This is what it means to be a champion, to be a leader, not just a follower of best practices, but a leader and a teacher and a role model. Okay, so to be a champion at your site, you also need to become a change management leader. You need to kind of become a mini version of what my team does. Being a change management leader does not require formal leadership training like members of my team. It requires a commitment to inspiring, motivating, and creating a culture of safety and best practices where they are the norm, not the exception. I can tell that you all have the credibility in this room. It's very clear from some of the responses and why you're here to begin with. You have the credibility and the knowledge and the experience to actually lead change. And this is my challenge to you. Use it. Leverage your credibility. when they're resisting change, it may not feel like they're respecting your credibility, but the fact that they're willing to speak up to you and tell you the reasons why means that they actually do respect you. And they respect enough of your background and credibility to tell you, A, that they're not going to do it, and B, why they're not going to do it. And you can think, oh, how dare they? How could they? I'm a champion. We are the champions. They need to just listen to what I'm saying. Yeah, maybe. Most do, but not all will. And here's the challenge. The ones that do the first time might just do because they say they do. But when they get alone, they don't always follow those practices. And that's what makes kind of nominal change, sort of change in name only, versus authentic change. And I believe authentic change comes from when those ultra-credible people like you decide, you know what, no, I'm going to lean into this one. We're going to spend some time here. I'm not going to write you off quickly just because you're resisting. Instead, I'm going to take what you're saying. I'm going to ask you at the huddle, how's it going? And if you resist and provide resistant comments and yeah buts, I'm going to take those in and say, thanks for sharing. Let's talk more about that at tomorrow's huddle. Let's talk about that at Wednesday Wednesday's our safe patient handling day. You know, there's a lot of ways you can structure huddles to sort of have the time for these kind of conversations. Change is challenging, change is uncomfortable, and change is inevitable. I think you don't have to look much farther than the current presidential election our country is in right now. It is a seismic period of change in our society, and it is no different, and frankly, it's expected why people might be more resistant in the work environment as well. There's a lot of change and uncertainty in the world, and sometimes people react to that by just, well, I'm going to kind of circle the wagons and at least control what I can control at work. And so sometimes you're going to feel more resistance in times of societal change. It's hard to talk about change management without really understanding what's happening on the ground. So let's share some few examples of how this plays out in the real world. As I said, I've spent some time in my time at MaineHealth in the hospital setting, Spring Harbor and SMHC, and now the medical group. So I'm taking these examples from there, but they could really go anywhere. So the first example, and this is in some ways kind of the ideal. We call this good partnership in public service. I can recall a situation where I witnessed two nurses, Sarah and Emily, where they were handling a patient transfer. Sarah, the more experienced nurse, was guiding the process. Emily, being relatively new, was hesitant, but she trusted Sarah's guidance. They communicated seamlessly, used the equipment correctly, and the transfer was smooth and safe. This is what good partnership can look like in public service: a shared responsibility, clear communication, and trust in each other's expertise. How nice. Now we have one called Not So Smooth the First Time. This should probably ring a bell. This is what most things are like. Another occasion, I observed a situation where a well-meaning colleague was trying to help a patient transfer, but it wasn't going smoothly. He chose to use the right safe patient handling equipment, but had been trained to use it, but was still relatively new to it and less comfortable. The result? The lift took a little longer, and the patient wasn't super comfortable in the moment, but everyone was safe. It's important to remember that everything takes time to master, including proficiency with these safe patient handling equipment. The more you use the equipment, the more confident and efficient you'll become. And please don't be afraid to reach out to your teammates or members of our colleagues here, our safe patient handling team, for any tips and tricks. This example is not a failure of intent. It's not a failure of good faith. It's a reminder that good faith alone sometimes isn't enough. That we must ensure that to achieve equality with the right tools, the right knowledge, and most importantly, practice and feedback. Notice it says not so smooth the first time. It could say slightly more smooth the second time, and even more smooth the third time. So these are kind of scenarios that I'm hoping will kind of help you see that change is hard and complex, and there's a lot of reasons why things don't work well the first time. I can assure you that as a former teacher, knowing the need to do better next time is truly part of the learning process. And for those parents or folks that know, young children in their lives, how we help children learn should really not be any different than how we help adults learn. I think there's this idea sometimes that like, well, you're an adult, you're 35, you shouldn't make mistakes. Like, no. We make mistakes all the time as adults. We don't check that when we turn 18. The third example, good faith, but a pressure to take shortcuts. There was another situation I saw where two colleagues were under time pressure. One knew that they could use the equipment, but were tempted to do the task manually because it seemed quicker. The intention was good, but perhaps the patient urgently needed to use the bedside commode. But this shortcut increased the risk for everyone involved. We must resist the pressures, and we must prioritize safety, even when the time is tight, which we know it often is. So hopefully this resonates with some of you. You've been in these situations. And the last one is one that I think also is similar to the previous one, but really just about misconceptions. The one before was about sort of time pressure. This one's about misconceptions. I've seen cases where a colleague insisted on manual transfer techniques, not out of ego. Again, we're starting from a compassionate, empathetic place here. If we're seeing them do something we know is wrong, as much as we want to have that kind of kick response, instead we kind of think, well, I'm going to assume that's not out of ego. Maybe they did it because they believed their proper body mechanics and strength were enough to avoid injury. I haven't gotten hurt yet, so why change? They might say. We heard one of those earlier. But relying solely on personal strength can be a dangerous misconception. Even the fittest and strongest of us, like me, can benefit from using the right tools, not just for their safety, but for the safety of their colleagues and their patients. I am not the fittest and strongest in the room. I pulled my hammy walking up here. I'm not even kidding you. So I was raking leaves this weekend. It's not good. So I'm making fun of myself. The human factor of patient care means that every transfer scenario is dynamic. Patients can assist or resist mobility, right? You all know this. This is why you're here. You understand this. And patient behavior and medical status are not always predictable. There is also evidence that colleagues can appear to be most strong and fit are actually at the greatest risk of injury because their peers request their assistance with these types of manual lift moments and tasks more often than others. So these stories here can illustrate the importance of teamwork, communication, and humility in our work. They show us that good intentions aren't always enough. Change is hard and complex. We need the right training, the right tools, and the right mindset to succeed. So let's get into sort of how we can specifically start to sell some of these practices. And I say sell because I think that's the right word. Remember, if we start from a place of like, they should know this anyway, they should be doing this automatically, I shouldn't have to teach them. You can take that approach. It won't get you very far, though. Instead, sometimes we need to see our role as a champion, as a salesperson. We are selling a new method as the best method for all of us to follow. So how do you do that? First is understand why they might be resistant. That little activity where I had you write down some of those responses, yeah, we laughed at them, and that's great. I love that. I think that's always sometimes cathartic laughter is a really nice way to deal with these resistant moments where you're just like, God, come on. Remember W.T. Blank, my daughter's response to a lot of things. But if we understand why they might be resistant, is it fear of change? Is it lack of training? Or is it simply a matter of habit? But understanding the root cause is so important. And once we understand it, we can address it directly. Here's my phrase, another one of my phrases besides change is hard and complex. Empathize, then equip. Empathize, then equip. So in other words, you can start with equipping, but if you have resistant folks, it won't land because they're not buying what you're selling. But if you empathize first and instead sort of try to seek what they're selling, because in some ways resistance to change is them trying to sell you on the reason why they shouldn't change. We heard some of those earlier when we walked around. Equip, empathize, then equip. Equip your team with knowledge, give them the tools they need, and most importantly, show them the impact of their actions. Let them see that safe patient handling and mobility is not just a policy, it's a promise to protect each other. So, before we change others, we have to shift our own mindset. Understand that resistance isn't personal, and this is hard, people. It's hard to not take it personal when somebody resists. Ugh. We have to say it though, but it's true. So sometimes checking our own ego when we have that initial gut response, like, no, you didn't, like, right? You know what I'm saying? Like, when you hear that and you're just like, I can't believe that person just said that. I can't believe that. The moment you take it personal though, you're going to make it harder for yourself to sort of bring about change in others. We are all in public service for a reason. So it's important to assume good intentions and good faith from our colleagues. I can't say that enough, people. Good faith is inherently present in public service work. It just is. We're lucky. We get to be surrounded by a lot of people acting in good faith. I can tell you that not everybody at Enron in the year 2002, or the crypto dude guy, whatever, Sam Bankman-Fried, like, there's some not good faith practices happening in other organizations, but in healthcare, public education, other public service parts of our society, you typically have a high degree of good faith. So as a champion, you need to approach resistant colleagues with patience and understanding. And we're going to, in a few minutes, provide you tools on how to do that. The last kind of tip I have, let's just watch the cute video for a second. Baby steps. I'll turn the baby off because it's distracting. I love that step of, like, you know, sort of that first step is like, we're really wobbly. They get that first step down, and what do they immediately do? They kind of like immediately want to take a second step. That second step is always a little quicker than the first one. Go, 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 go. Look at the smile. Oh my goodness. Okay. Baby steps is a term we use a lot in change management. Change is as much about patience as it is about persistence. Celebrate the small victories. Don't get encouraged by setbacks. You could have a great huddle conversation on a Tuesday, and Wednesday it just bombs. Or Wednesday somebody gets hurt. And it's like, well, we tried your technique. Look at what happened. Right? Yeah. Sometimes you take one step forward and two steps back, but you always come back to those baby steps, those incremental steps. The journey towards a minimum manual lift environment, it's a marathon, not a sprint. However, no one is going anywhere unless you mark the starting line and the ending line. The ending line, the cookie. Hey, at least the baby's clear what the target is. I'm trying to get that cookie. I know what I need to do, and I know what I do to get there. Keep your focus on the end line, that long-term goal of being a minimal manual lift environment. All right, one more little plug here, because this is something I've touched on a couple points. In my research that I did for my doctoral program, I studied this thing called public service motivation, which is seen a lot in research. I think it's misunderstood a lot. I think it's misunderstood by policymakers and executives potentially who decide compensation for public servants because they think, oh, well, they want to work in public service, so they'll get paid anything. They'll be fine with it. So I want to be careful. That's not what I'm saying here. But there is a pretty tried and true research on this very issue of public service motivation. And there's this quote here that I feel really kind of speaks to that. I can assure you, public service is a stimulating, proud, some days, most days, and lively enterprise. Public service is a stimulating, proud, and lively enterprise. It's not just a way of life, it's a way to live fully. And hopefully that resonates with some of you as to what public service motivation is about. Our shifts are hard sometimes. Our experiences are hard sometimes, but we also get a lot of moments where we feel like we're living fully. And that's pretty cool. So I trumpet that a lot today because I feel, in my experience in both public education and now public health, that tapping into public service motivation as a vehicle for why change is necessary is a really helpful tool. It's this idea that we are all in this work for the right reasons, to help patients. But in public service, no one is ever alone. We always need each other to serve the public. And that's very true about public service. Even police officers who are out on their own, the moment they have a call, they immediately notify a colleague, and that colleague comes to their side. It's almost consistent in all parts of public service that a person is never alone. Just think of how much we learned about that during the pandemic when our systems were most stretched. And I was a principal in the pandemic in schools, and holy moly, stretch city. However, you all showed up. You worked alongside your colleagues, and you had your colleagues back. And even the most scariest of times, we served our communities when they needed us the most. In public service, we are never alone. I'm telling you this because I think you should say this to your colleagues. I'm being direct and clear with you here. This is a good thing to use, good language to use when you're talking about change, specifically safe patient handling and mobility. So much of the best practices rely on people working together. And so you start with that. You know what? In public service, we are never alone. And remember, your daily unit huddles are the perfect place to drive this change. These huddles are more than just meetings. They're opportunities to discuss and reinforce best practices. You can also use them to put something like relating to safe patient handling on your department scorecard, run a KPI or PDSA cycle at your huddles about something relating to safe patient handling. There's so many opportunities. And as I said, each of you have somebody at your site in my role that can help you with this. All right, now I want to get to some of the tools that we have here. Okay. In your folder, you should have as the second sheet on the right side at the top. Can I grab that since you have, it looks like this. Okay, this is the last thing we're going to do here as part of the keynote. Hopefully I've given you some things to think about in your mindset and approach. Now I want to give you some specific tools. So, as we did earlier, we collected your responses of things that your colleagues would say to you when you came back from this conference and said, hey, I learned this, I learned that, and they kind of come back with some yeah buts. So in addition to us kind of doing that activity, we want to kind of highlight some of the most common yeah buts that we saw. And then we want to give you some specific scripting that you can use. When I say scripting, I do not mean you need to say this exact thing. In fact, I probably wouldn't recommend that. You could start with that. But the reason that there's a blank space next to there is because I want you, as you're thinking about this, to say, yeah, I wouldn't say it that way, but I might say it this way. This is another way I could say that. That makes sense. So I'm going to show you some yeah buts that we saw earlier, and then I'm going to give you some specific scripting that you could respond to that. And I want you to put it in your own words on this sheet of paper as it comes up. If you feel like what's up here is truly the best response, then write that down too and use it. But really, the scripting is really more to inspire you and to think about how I might respond in these yeah buts moments. I told you kind of philosophically how to respond, which is empathy, public service, listening, catching what they're saying. I've given you a lot of kind of philosophical. These are more specific. So, one of the biggest things you might hear is maybe a legitimate concern. What's the point? We didn't really hear that one when we went around, but I think that's maybe in a couple of them was implying that. What's the point? Well, here's something you could say. Well, I'll tell you what the point is. MaineHealth has a vision on this. We are a minimal manual lift environment. These strategies and equipment can help reduce manual patient care and risk for injury. That's a response. Write it down if you feel like that's something that you might say. And if you don't feel like you'd say that exact thing, write a couple bullet points of things that you might respond with. Here's another one. The use of our equipment is safest for the patient too. It can reduce skin shearing and risk for falls. I think that's a pretty good response. Kind of come back with a yeah, but with that. Yeah, I hear you. Yeah. It's also important, I hear you, and it's also important to know that it's actually safest for our patients too. No, it's not. Well, it's safer when I do it my way. Yeah. Well, the data shows that it actually can reduce skin shearing and risk for falls. Next one. You might hear, well, I don't know how to. I want to, I just don't know how to. So how could you respond to that? This is a data-related one. Well, most caregiver injuries related to helping patients move are cumulative. I actually didn't know that one until I started working with this team. I figured they were more kind of critical moment injuries. No, most are cumulative. Every time we use the right equipment, we reduce the additive risk for injury. So if that resonates with you, write it down. These are tools, these are things you can bring back. Here's another one. I don't feel it's safe to do this task manually. I don't want anyone to get hurt. I'm happy to help if we use the right equipment. So use your leverage in that collaboration and never alone moments to say, yeah, we're never alone, but I'm not going to do this with you. I'm not going to. I'm going to wait until we use the right equipment. Here's one. Don't have the right tools. I will show you how to order it. I will help you find the equipment so you know how to do it the next time. I'll get the equipment for us. Yeah, I think I skipped this one. Thank you. So you might often hear, well, it's quicker to do blank. We saw that in one of our examples. It's quicker to. I think I did this one. That one. All right. This is probably a common one. Well, I would do it. Patient saying no. I'm trying. Patient's not playing ball. This is some things you could say to the patient. What part of this feels scary or uncomfortable to you? What questions do you have? Sometimes it's working with resistant colleagues. Sometimes in this world it's about working with resistant patients. Educate. Using this equipment helps prevent you from falling and helps to keep me from getting hurt from lifting. You've just now seen some examples here, and I asked you to write down your own thoughts in response. We're going to give you a tool when you leave this room that's going to have all of these written on it. So I only asked you to put it in your own words if it's something resonated different, but we're going to give you this tool that has all the scripting on it. It also has some of the core standards of safe patient handling on the front. It also has a little hole and a little spot that you can hang it from something. Hang it from your huddle board. Hang it from where your equipment is. Use this tool. Put it out there. Show it to people. Tell people, I got this at this conference. When we talk about safe patient handling, we should be using these types of phrasing and responses. Hang it next to your equipment. Use it, abuse it. If you need another one, we'll give you another one. Please don't put it in a folder. It probably won't get used. Encourage you, we're giving it to you in a form that you can actually use it in the environments where we talk about this stuff. My last little plug here, this is my team. I was going to say, I think Amanda Kunkel's in this folder. She used to do our work as well. Now she's the rehab director in Biddeford. So my point is, like, we have a team of people here to help you with how to have these conversations at huddles. Each of you has us. Today's discussions and best practices are not just ideas, they are actions waiting to happen. Take this energy back to your hospitals and your practices, use it to fuel your efforts, commit to action, and don't let today's insights stay here. Bring them back, implement them, and watch transformation happen. Thank you for your dedication, your passion, and your commitments to making healthcare safer for everybody. Thank you.